And welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dayna and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based. The whole idea of this weekly podcast is to review recently published articles in the area of child health and to draw out some real key points that can be incorporated into our practice. We'll have the absolute privilege of talking to some of the authors and some leading researchers from all over the world to hear their thoughts, their recommendations and their tips that can really help us as clinicians to achieve the best outcomes of the people that we work with. So my name is Dr. Dayna. I am both a researcher and a physiotherapist in the area of pediatric neurorehabilitation. I've actually worked in this area now for nearly 17 years, and that's a long time. And I just love how much our profession has evolved over this time to becoming more and more evidence-based. I've worked both in the community setting as well as in the hospital setting here in Perth, Australia. And currently my roles are as a postdoctorate research fellow at Curtin University and clinical lead at the Healthy Strides Foundation.
And I'm Dr. Ashley Thornton, also a researcher, and my background is in exercise and health science. I've been studying and working in the area of motor learning and development for close to 13 years now. And I'd have to say my favourite part is definitely the knowledge translation side of things. So getting the right information to the right people in the right way, which is one of the reasons why I am so excited to be part of this podcast.
I love that. I think when we start talking about how long we've been doing this for, does it make you sound really mature and maybe on the older side?
Old is what I was going to describe it, but sure, mature. So today we're going to talk about an article that was recently published in Developmental Medicine and Child Neurology. The title of the article is Locomotor and Robotic Assistive Gait Training for Children with Cerebral Palsy. And the reason we wanted to talk to you all about this article today is because it describes an intervention delivered to children with cerebral palsy that are quite dependent on equipment and physical assistance throughout the day. And for this particular group of children, the options for interventions are often quite limited. So it's really exciting that we can break this down and talk through this particular intervention a little bit more. The other bonus to this article is that it's actually authored by our very own Dr. Dayna.
I think that we have a great article to review today. Not that I'm biased in any way, shape or form, but like Dr. Ash had said, should I call you Dr. Ash? That seems more formal.
Overqualified.
Your PhD. But we have an amazing authorship group for this as well. We have Dr. Jane Valentine, who you will hear later on in the Research Works podcast, Nicholas Taylor, Natasha, as well as Catherine Elliott. So let's get into some of the main features of this actual study. So we'll describe each of the studies according to the PICO format. And it's a really nice way to describe how studies are. So PICO, P standing for participants, I for interventions, C for comparison, and O for the outcomes. So for this, the participants were children with cerebral palsy aged between 5 and 12 years. They were all classified as having a GMFCS, or a gross motor function classification system, of 3, 4, and 5. So really children that were dependent on equipment and physical assistance throughout their day. The age range, like I said, is 5 to 12 years of age. So really that sort of primary school age. The main feature that we needed for children to be part of this study is to be able to follow some simple instructions, whether that was through a communication device or verbally itself, and to ensure that they didn't have uncontrolled seizures, because that was something that we wanted to make sure that we wanted to keep everyone really safe, particularly when putting them upright. And of course, if they had orthopedic surgery in the last 6 months, to not be part of the study as well, just mainly looking at the weight-bearing component of it. Now, the intervention, we had 2 main interventions that we were comparing to in this randomized controlled trial. So the first group, or the treatment group, was really the robotic group, the robotic assistive gait technology one. And for this, we used the RT600, which is this really incredible device that's like an elliptical trainer that provides functional electrical stimulation to the muscles in the leg. So children used that for 20 minutes, and then they went through a standard protocol of locomotor training over the treadmill. And that went for about 20 to 30 minutes as well. Then after that, they spent some time over ground in their walking frames if they needed that, to really work on their skills, over ground in that indoor sort of environment. So that was one group. So they had all 3 of them, locomotor training with the addition of robotics. Now, the second group, or the control group, was the children who underwent locomotor training only. So they didn't have any robotics, they were on the treadmill, and then they also had overground training. So that was the comparison. We compared them through 3 main time points at baseline, obviously, to see where they were at. Post-treatment, which was after 6 weeks. So children came 3 times a week for 6 weeks, so 18 hours of intervention. And then after that time point, they came in again at the 6-month follow-up period. So 3 assessment time points. With regards to the outcome measures, our primary outcome measure was the Goal Attainment Scale, or the GAS for short, and that's a real individualized way of objectively assessing goal attainment in children. So it's still very individualized, but there is an objective method of writing these goals and assessing them. The other measures that we use was the 10-meter walk test, the speed it takes to walk over 10 meters, the functional independence measure for children, or the WE-FIM, which is really looking at self-care, mobility and cognition components, and that's a semi-structured interview. Then we also had the Canadian Occupational Performance Measure, or the COPM, as well as the Gross Motor Function Measure, or the GMFM. And as you can see, we love these long terms and acronyms, and we'll use them interchangeably throughout all of these because I feel like there's just a lot of words there. So the main result we found from there was that there were no significant differences between the groups in any of the outcome measures. So we really noted here that the addition of robotic assistive gait training to locomotor training does not produce any significant improvements in motor outcomes in children with cerebral palsy. And our main conclusion was also to say, well, maybe future studies should be investigating the use of health and wellbeing outcomes after locomotor training.
So Dayna, what do we mean? What's the clinical interpretation of no significant differences between the 2 groups that you looked at for this study?
Yeah, so that always seems a little bit sad when you go, there's no changes after a study, but this was actually quite significant. We had originally hypothesized that the addition of robotic training would mean that there would be greater improvements in outcomes. And the fact that there are no changes doesn't necessarily mean that children didn't make any improvements. In fact, when we look at the within group changes over time, they all made changes across the board over all of those time points. But because both the groups made changes, you couldn't actually detect any differences between using robotics and just using simple equipment like locomotor training alone.
So that magnitude of change wasn't any different between the 2 groups.
Yeah, that's right. So I think the exciting thing about that, even though I felt disappointed to know that, the use of robotics and all this technology wasn't significantly better, it does mean that you can use this intervention in any other setting. If you don't have that kind of equipment, which, let's face it, most community environments don't have that kind of equipment, you can still do this in community settings and still hope to see changes across the board as we'd reported.
Yeah, so having access to that robotic assistive gait technology isn't necessarily a barrier to eliciting improvements in functional outcomes for these kids.
Yeah, that's right. So yeah, definitely a bonus and an unexpected bonus, but it was really good to actually see that as an outcome.
Yeah. And do you think, though, that having access to that robotic device provided some maybe additional benefits around motivation or novelty for the kids?
I definitely think so. I think when you have technology, there's something about this generation that loves technology. And when you put that in front of them, they lap it up. So I guess what you can't appreciate in a randomized controlled trial sometimes, and that's it's a higher level of evidence, is you don't get the intricacies of the children that sort of perform outside of the means necessarily. You don't really appreciate that. And for some children, the fact that they had that interface in front of them, they could see how much they were weight bearing and how much weight they're putting through and how much effort they were doing and how many meters they were doing, that was really motivating for them. And it didn't matter how much we were cheering them on in another setting, the fact that they could see that sort of biofeedback in a way was a really positive factor. And the fact that it was different, people were more intrigued by it. Parents were intrigued by it. What could this possibly do? So there is that slightly high expectation, which I think does help with motivation and compliance with the intervention.
Mm-hmm.
Yeah.
And for therapists who maybe don't have access again to that robotic technology, are there ways that you could elicit that motivation and novelty factor into the more traditional locomotor training, do you think?
Yeah, I think so. I think what we did the most, especially in the control group when we didn't have that, is we just worked more on what the child really liked. And a lot of them liked songs and, songs where when you're walking along, you can walk to a certain rhythm. So people would often hear us singing "The ants go marching one by one, hurrah, hurrah," and we would be singing that all the way to 10, making up our own little versions of it. But having that seemed to be fun. We were stepping over bean bags, stepping over toys, pretending to put things on the treadmill that they had to splash, or they'd do so many steps and they would get a particular toy or a motivation. So you do need to work that little bit harder. But in saying that, we also were doing that when they're on the RT600 as well. You're still wanting to keep them as engaged as possible, because even though the device encourages you to do so, it does still require the child to actually be part of it. So you are working quite hard to keep them onto it for that time.
And finding what works for them, what their motivators are.
Yeah, not everyone likes ants go marching in, but hey, as a choir, I think therapists can definitely learn that song.
Add it to their repertoire.
I think so.
I wanted to talk to you a little bit about the goals that the family set for the children during this intervention. Could you talk a little bit about how the goals perhaps varied across the GMFCS levels?
Yeah, that was really awesome to actually tease that out from the COPM as well as the Goal Attainment Scale. So as you'd expect in the GMSS level 3s, a lot of the goals were based on improvements in their walking speed, their pattern, their endurance, their fitness, their ability to participate in phys ed, for example, to be able to run. So it was really based on that higher, gross motor skill level, and more so about patterning and speed. And you could really see why they would go down that path. They were great goals to be set. In contrast, with the GMFCS level 4s and 5s, their goals were very, very functional. I think a lot of times when you talk about locomotor training, people go, oh, you're working on walking, and you should really be careful about working on walking for children with GMSS level 4 and 5 because they're not going to be independent. And we appreciate that. We know that. And the parents also knew that as well. But they saw it as an opportunity to engage in physical activity. And that was a common goal for them. It was just find an opportunity to be engaged in some form of physical activity, something that is not just sitting. And the really interesting factor was the link that parents made between physical activity and practicing standing transfers. That was something that was common as well. They just wanted to maintain the ability to step or standing transfers, or stepping to the side so they could actually do a standing transfer as well, because that is so functional. Some goals were based around dressing, so being able to lift one leg up at a time so you could put your pants on, or to be able to stand whilst they getting the rest of the clothing ready. So really functional self-care things at home. And then there are other ones that were based around care and comfort and pain. And I thought they were really interesting goals that were being set as well, because parents were really making that link between physical activity and managing comfort. And we know that from all the literature about exercise and what that does. So some of the goals were really based around pain management, but also around bowel movements as well, and being able to keep upright and having exercise so they have that opportunity. So it really was quite varied, and it was really nice to see those goals being set. So that really points out to us as clinicians that we need to be looking across the board, not just it's stepping and walking. There's so much more to it.
Absolutely. And I think that's something that I really took away from the paper as well, is that, movement and physical activity is so important for everyone. And it's not just about being able to step and take steps and move in that manner, but it's all the additional health benefits to being able to do that on a regular basis, particularly for GMFCS level 4 and 5. Those kids, don't often get the opportunity to move around. They are quite limited in terms of their ability to do that. So any opportunity to actually get up and move, even though, it is supported and it does require assistance, it's still really important.
Yeah, I think so. I think it's just been really clear we're not just looking at that independent movement, which I think is always associated with it. It's been really clear about the goals, and seeing this is really helpful. And how common is it when families are asking for their children of GMSS level 4 and 5 is, what else can we do? How else can we get them more active?
Yeah, and it's not just those outcomes related to their motor function. It's, like you say, improved bowel functions, improving their transfers, we all know how much movement improves our mood and our confidence and self-esteem. So
right.
Having the opportunity to do all those things is, incredibly beneficial.
It is. And I always go back to the times, I know we're not traveling very much at the moment, if at all. But, when you are sitting in a long haul flight and you have no choice but to sit in that really squishy economy chair that you just want to get out of, all you want is to be able to stand and to move. And we know what that feels like. And I think it's just thinking about that and putting yourself in that situation and going, what would be nice for you in that time?
Yeah, if you've been sitting at your desk all day and those endorphins are not flowing, you just want to get up and move. So I think we do need to be mindful that everybody feels that way.
With studies like this, I think there's a lot of things that you can't actually put into the paper. And what I found for this paper was that, yes, we were able to report on these outcomes, which really were these activity and participation-based outcomes. They were really, just quite standardized ones where you couldn't really appreciate the individuality component of it. And I found that quite challenging to be able to report in this paper.
When you're combining everyone into a group, you're not necessarily teasing out all those intricate differences and changes over time.
Yeah, that's right. That's right. And I think when you're carrying out an intervention like this, yes, you standardize it as much as possible. You have the fidelity checklist. You know that you're carrying out in a certain way. But, you are therapists, you're responding to children, you are responding to what they like and their mood on that particular day and what they gain out of it. And, you don't really see when they're making those changes as well, because we're really just looking at those 3 assessment time points. And I guess one of the things that I just wanted to sort of highlight as a researcher and as a clinician is that it is still so individual, and that you can get changes that happen at a different point in time, because we chose the dosage of 6 weeks based on what families have said they could do. Because when you have a wheelchair to bring to the hospital, for example, 3 times a week over 6 weeks, it's a huge ask.
Even just finding somewhere to park.
Oh my goodness. The parking situation in a lot of hospitals was tough. In fact, one of the things we did for this study is we actually paid and leased a car parking bay that was close by just to help, because when you have equipment to bring, that is really tricky. So we did go slightly below the exercise recommendations, which, as we know, the recommendations have come out recently, is 3 times a week, 60 minutes for 8 to 10 weeks. And we only went to the 6-week mark. And for that was trying to manage that burden component that we know that families often do experience. But I have to say that it would have been really interesting to do the full length and go 8 to 10 weeks if that was even feasible for families.
Yeah. And I suppose the other important thing as well is that you did see improvements in those 6 weeks.
Yeah. And it just shows how quickly you can make those improvements. So is that because, they've been sedentary for so long, and so when you do finally get up, you can make this big improvement? So that's interesting. And it's interesting at that 6-month mark, they maintained that improvement as well when you compared it to their post-treatment. So they were maintaining some of those improvements. And I guess I'd be interested to know what they were doing during that time. Were they more confident to be in their walking frames, so therefore upright more often, and now had the opportunity to keep moving?
And that was the stimulus to be more active.
Yeah, that's right. Because I think so many times working clinically, what I often saw was you'd hand out a walking frame and you would want them to use it at home, but it was never really accompanied by training on how to use it. So you'd see them again, a few weeks later, and they're just, learning to take a step in it, and it's still so effortful and it's really hard work, and then it sort of falls off because it's just not efficient, the effort it takes to then transfer into the walking frame. It just becomes the too hard basket. So I'd be really keen and interested to know what happened between that 6-week and that 6-month mark of why they maintained it. Because if you're not active, you would definitely decline in those measures pretty quickly.
Absolutely. And maybe it is that confidence to, maybe the 6 weeks of training wasn't enough to establish the confidence to carry on those patterns, in everyday life beyond the scope of the study.
Yeah, that's right. So I guess, that is an interesting point. We're going, 6 weeks is that minimum time. You can do more if it's feasible to, but 6 weeks is sort of what you need to get going. And I guess from there, on a serial basis, how often should you do it throughout your lifespan? You don't want to be doing this all the time, but do you do it every 6 months, or do you do it on an annual basis as you're growing, or, when do you do it again? Those are really interesting questions to ask from here, I think.
Yeah, absolutely. As there are key kind of milestones throughout childhood, is at the point where you need a little booster or, a revisit of any modifications that need to be made to that equipment that you're using, or, a big transition in life is an opportunity to kind of revisit this locomotor training and
Yeah, and I think that's a common question, isn't it? It's like how often and when should I do it? And the only literature that I can really refer to back for that, there's two things. There was a case study that was done on a young boy with a spinal cord injury that had locomotor training, and they actually followed him over quite some time. And their recommendations were really to implement locomotor training when there's significant biomechanical changes. And you go, well, that makes sense, doesn't it? When you know that the work that Adam Shortland's done and looking at motor capacity or muscle strength, we know a lot of people with cerebral palsy don't have enough motor capacity or muscle strength above the threshold that's needed for function. So as you get taller, as you put on some extra weight because you're growing, your muscles don't have the capacity to cope with that. And therefore, you're not able to engage in much physical activity. So it's important to maybe identify those times where you're about to go through a growth spurt, perhaps, and that's when you can do some training. And, this is really inferring from research that's been done through muscle health, but it does make sense because, you can't just do it once off and expect changes long term. It's something that needs to be done again.
Absolutely. And so I just wanted to, I know we've kind of gone through that section as a bit of an interview anyway, but I just had a few extra questions that I wanted to ask of you with your author hat on, Dr. Dayna Poole.
Okay, sure. All right, here we go.
So I'd love if you could talk to us a little bit about the background and what kind of led you to the point of conducting this study in your clinical life and your research life.
Yeah, so the reason why we felt that this study was so important was because there are so many children with GMFCS level 3, 4 and 5, particularly 4s and 5s, that don't have many intervention options. The desire to be upright and to move is so strong, and that's both for the child and for the parent. And we were just finding it harder and harder to find ways for particularly school-age children to participate in that. Sure, when they're under 5, you can facilitate that and support that. But what is it that you can do? And then we're looking more into the literature about exercise and the recommendations. We're going, well, how can we actually find an intervention that can do this? So that's what really led to the idea of translating locomotor training, a very specific technique really from the spinal cord injury literature that's had significant paradigm shifts through how people are treated if you have a spinal cord injury, and going, well, there's a lot of similarities there. How about we look at that in this population? And then we were doing some work in electrical stimulation, and we know that electrical stimulation can be so great in building muscle strength, awareness, and really increasing activation. And then the RT600 came along, and that was a device that had all of that and had people upright as well. And so we really translated a lot of that, which was really for spinal cord injury, and went, okay, let's see if we can translate this to cerebral palsy and see whether this can be effective. But I would have to say the big driver for this was families. Families were just constantly asking, what else can we do? What else can we do? And I was just running out of answers of things that were actually effective. And that's what led to this.
I know that it's something people often ask you about with regards to this paper is the impact that hip status had on the intervention. Could you talk to us a little bit more about that?
Yes. Hip status is a really big one. We know that, a lot of children with cerebral palsy, particularly if they're level 4s and 5s, is that their hips might have a greater migration percentage. And is it safe to weight bear? Is it safe to be upright? Look, it's really important to have the clearance of the orthopedic team for this, because they'll know, they've seen it. They know whether that's the case for them or not. But the key factor here is that it is partial body weight supported treadmill training. And it's the same both in the robotic as well as over the treadmill. So there is essentially a harness that holds the child up, and we start with a percentage of body weight support. So to start off with, the child's not taking too much weight themselves, because we want them to work in fast-paced walking without the limitations of holding their whole body weight up. So if you have a hip migration percentage that is sort of on the cusp, I'm not really quite sure, then we do make sure we provide more support. And it is quite an abducted position anyway, because you've got all the strapping that keeps them more abducted, which is whole lot safer. But then again, it's really important to make sure the child can express discomfort as well. So that was the main criteria of being part of the study. So it's something always worth considering. It's not a one size fits all, and it's one as you would clinically discuss with the team.
And what about cognitive capacity of the kids that were involved in the study? Was that a consideration?
Yeah, so cognitive capacity is something really to do with their ability to communicate really basic things to us if there is pain, and to be able to locate that pain necessarily, and also to be able to express whether they wanted to go up or offer at one point in time. We do encourage children as much as possible to participate in activity, so getting them to step over things or be in the walking frame as much as possible. So if they have a simple ability to be able to follow that, then this is definitely something that can be tried, because we certainly were able to do that in the study.
And is there anything you would have done differently if you could have started this process again? If you could speak to past Dayna and give her some advice?
Look, what I would probably do is first up probably include the 6-minute walk test in this. I found that the 10-meter walk test was great, but there's a ceiling effect, because at baseline, children who were not able to complete the test were maxed out at the 6-minute mark. So it made it really hard to analyze, and you couldn't really appreciate small changes. So if they were only able to take enough steps to cover 2 meters, and the next time they finished, they were able to cover 10 meters, then you can actually appreciate that change. So I felt like that measure could have been done a whole lot more. We did take some actigraphy measures that didn't make into the paper, because they weren't really a reliable measure for GMFCS level 4 and 5. So I think some work on that are going, well, what's the actual dosage? How many steps do they need to take, rather than just hours? Because, I can go to the gym and say I went for an hour, but I can also look at my heart rate and what else I did and how many steps I actually took. So there's just more measures to help you kind of figure out the dosage. I reckon those would be the things I would have done.
Yeah. And is there anything else that didn't make it into the paper?
Oh, yes. The biggest part of that is the qualitative component. We were able to take some interviews at the end of the intervention for both children, for parents, as well as a therapist. And look, that is just bigger than was able to be put into the word count for this count. So it would have been lovely to be able to present both the quantitative and the qualitative side by side, because it makes so much more sense. I wish we were able to do that.
And could you talk a little bit more about the therapist experience as part of this intervention? I imagine they received a lot of support and training to be able to carry out the locomotor training and the robotic assistive gait training. Is that an important thing to consider for clinicians who are looking to implement this kind of work?
Yes, absolutely. I think that's hard to appreciate in the paper as well. It does require really specific hands-on support, and knowing when to take your hands off is really important as well. And that's all in line with the current evidence of, the hands-off approach. So facilitation is only in there to generate enough sensory input for central pattern generators. So that does need really specific training. It's not just a matter of putting a child up, harnessing them up and getting them to step and helping them to step along. There's a very specific technique that's involved in locomotor training. So that's really a great way to training your team as well, to be able to go through a checklist of what steps you need to be able to take. And we really manualized all of this as well, so that we all had a very set formula of how we were going to carry it out.
And that's so important from a professional development perspective as well.
Yeah, and I think that's where it's great having research that's integrated into clinical practice, because as soon as we were all able to do that, your clinical practice improves already, because you have that feedback and that constant ability to provide that feedback through the study.
So if people wanted to upskill in locomotor training, where are some places that they could go for more information?
Look, I definitely think the Americans are leading this. They have a lot of courses that are being held in the US about locomotor training. Susan Harkimer and Andrew Berman are the main people who are the ones that really developed this. There are centres across the world who are now doing locomotor training. You'll probably find a lot of that in the spinal cord injury rehab setting, more so than cerebral palsy. I mean, we're just starting that now, and hopefully we can start to roll that out more.
That's really exciting.
I know, it is very exciting.
And so final question from me, what would be your take-home message to people who have listened to you talk about this paper, and it's obviously an area that you're really passionate about? What would your message be to those people?
All right, well, my main message would be children who are GMFCS level 3, 4 and 5, your 4s and 5s in particular, they can participate in locomotor training, whether it's with the addition of robotic assistive gait training or it's just locomotor training alone in combination of overground walking. It is something that we should be considering, and considering as early as possible, and to just really consider the goals beyond just the motor goals. The motor goals are really obvious for a physically based intervention, but to think of the whole effect across the lifespan and what this would mean for them in the long term, and just those real functional care and comfort kind of things. So definitely consider this as an intervention.
Absolutely.
Thank you very much. All right, well, we have a very special segment that's called Tell it to Ed. So Ed is our producer, and he isn't in the area of child health in any way, shape or form. And he is someone that listens a lot to what we're talking about. And the key question here is whether he actually understands what we're trying to say and whether we can put it into a main message in 1 minute. Welcome.
Thanks for having me on the show.
Hi, Ed.
How you doing?
Good.
All right, Ed, are you ready?
Absolutely.
Do you feel like you've learned something today?
Yeah, I definitely think that I've learned something new. So that's kind of cool.
So there shall be a quiz at the end. So for all of those listening out there, this is a way that we can quiz people whether they've understood us or not. All right, here we go. So Ed, locomotor training is a way of training stepping patterns for people who have neurological conditions. So this is when there's an injury to the brain or to the spine. So this form of training is actually safe, and it can be provided to children as young as 5 years of age and may need equipment like wheelchairs or physical assistance throughout their day. Now, what this study suggests is that children with cerebral palsy, neurological conditions, they can undertake locomotor training in a really safe way. And if you add the use of robotics, so to a device that can help them to move with a mechanical machinery rather than just with human support, you can actually make some improvements over time, but you don't necessarily need to have the robotics in place. You can just have people carrying out the intervention over a treadmill with the use of a walking frame, and the improvements you can see can be with goal attainment, really reaching their own goals, improving their ability to walk over 10 meters, as well as having some improvements in their gross motor skills as well. So it's something that we should be considering, but we should also be considering the use of using locomotor training for overall health and well-being, not just now, but into the future.
Wow. Very, very cool.
Do you feel like you understood that?
I think so.
Do you have any questions?
Yeah, look, I think I'm really intrigued by this, but I'm still a little unsure about the differences between locomotor training and robotics. Is it all the same?
Okay, great question. So robotics is when you have a device that does all the movements for the person, and it's really driven by
An exoskeleton.
Yeah, like an exoskeleton kind of thing where it's very much in its external, it's hands off, you need less therapists. And the main reason why robotics came in is just to have a real standardized way of training. It also removes the extra humans that are required as part of it as well. Yeah, so the idea is you can, use it for many, many people. Whereas locomotor training really relies on people to feel what's happening. You're using people to move the limbs, and this is for stepping, so you're having them to step over a treadmill. And you're using a very specific technique to help them to be able to take those steps.
Very cool.
Any other questions?
No, I think that actually covers it really well.
That is great. All right, well, we'll call that a success.
I think so.
I think so.
And everyone at home can practice telling it to Ed as well. Once they have digested all of this information, they can go away and tell it to their own Ed at home.
Happy to help out.
I like that. All right. Well, thank you so much for listening to the ResearchWorks podcast. Now, the run sheets for this entire podcast, as well as all our upcoming episodes, will be available on our website, researchworks.net. And if you want a copy of your time to listen to this as part of your CPD, there'll be a form that you can fill out online as well, where you'll have reflection notes, which you often do need to show as proof of your CPD. So we can help you keep a record of that as well. But really excitingly, next week, we'll be reviewing an article about sleep, temperature, and cerebral palsy. Our special guest next week is Dr. Sue McCabe, who authored all of these papers. She is incredible. You're going to want to hear this from her. Sue McCabe and I will have constant conversations about this. And every time we have a conversation, I feel like I walk away feeling way more smarter and being a way better clinician. And her thoughts about this is going to be really intriguing.
And some great takeaway messages we can implement into our practice.
I love that. All right. Well, thank you very much. And we will talk to you again soon.
Thanks, everyone.